Welcome back to the Deep Dive, the space where we translate the cutting edge of sport science directly into practical, evidence-based insights for you, the medical professional.
Hello.
Today, we're undertaking a deep dive into the very engineering of human endurance. We'll be examining that fine line high-volume athletes must tread to optimize performance without tipping into injury or systemic maladaptation.
Indeed. We're stepping onto the training track, so to speak, to review the latest evidence.
And what's on the agenda?
Well, our discussion will cover the physiological cost of concurrent training, the real efficacy of different intensity distribution models, and the quite demanding nutritional strategies for ultra-endurance.
And perhaps most critically for a clinical audience, we'll get into the complex and often retrospective diagnosis of overtraining syndrome.
Exactly.
Our mission is really clear: to distill the physiological context you need in a clinical setting, helping you support those highly motivated patients, whether they're training for their first marathon or their 10th Ironman.
And that level of precision is becoming more and more vital, isn't it? The sheer volume and intensity of amateur athletic pursuit just continues to rise.
Okay, let's unpack this, starting with the fundamentals. For this audience, we can assume the basics of progressive loading and specificity are well understood.
Of course.
But where do athletes and the clinicians advising them most frequently violate these biological laws, leading directly to injury or maladaptation?
That is the right place to start. The laws themselves are simple, but it's the application where all the complexity lies.
I see.
The greatest violation of progressive loading. Well, it often happens when an athlete, perhaps after a break or just feeling highly motivated, tries to accelerate the rate of load increase far beyond the biological capacity of their tendons, bone, and connective tissue.
And that's when they turn up in your clinic.
That's exactly when. You see the classic signs of system failure, stress fractures, tendinopathies. It's almost always a case of nonlinear load progression.
So, the body needs structured recovery to achieve adaptation and supercompensation. How often do we see athletes sabotaging this by misinterpreting what adequate recovery actually looks like?
Constantly. Supercompensation is the body's rebound to a level higher than baseline after rest. The sabotage, as you put it, comes from a profound misunderstanding of the biological timeline.
It's not an overnight process.
Not at all.
Yeah.
Adaptation is an inherently slow molecular process. Athletes often confuse their tolerance of training stress with adaptation to it. They feel they can handle more load, but the underlying tissues haven't fully remodeled yet.
Their drive to improve quickly gets in the way.
It does. It leads them to shorten that recovery interval, which is the direct pathway to chronic, low-grade inflammation and overreaching.
And when we think about specificity and reversibility, particularly for those of you working in rehabilitation, the message has to be precise. Does generic conditioning, for instance, really translate to high-volume running?
Absolutely not. And this is a crucial point. Adaptations are specific to the energy pathways and muscle fiber recruitment pattern to stress.
So strength training doesn't really help your marathon time beyond a certain point.
Correct. Endurance training enhances aerobic capacity and type I fiber endurance. Strength training targets maximal force and type 2 fiber hypertrophy. If an athlete stops running and shifts solely to heavy lifting, the cardiovascular gains disappear quite rapidly. That's reversibility in action.
Let's pivot now to Zone 2 training. Before we even get into training structure, does the physiological zone itself, specifically Zone 2, hold a unique therapeutic importance for these patients that warrants a deeper look?
It holds immense therapeutic importance, extending far beyond athletic performance right into preventative medicine. Physiologically, Zone 2 is that sustained, moderate intensity where the body primarily uses fat for fuel.
And that's below the first ventilatory threshold, VT1.
Yes, where lactate production is matched by clearance, keeping levels below about 2 millimoles per liter. For most, that's a heart rate of about 60 to 70% of maximum.
So why is this specific intensity so potent for longevity and metabolic health? What's happening at the molecular level that distinguishes it from, say, an easy recovery jog or high-intensity intervals?
The power lies in its direct and sustained impact on the mitochondria. Zone 2 provides the optimal stimulus for what we call mitochondrial biogenesis, the creation of new cellular powerhouses, and just as importantly, improving the function of the ones you already have.
And this process is orchestrated by PGC1 alpha.
That's right, PGC1 is often called the master regulator.
Can you elaborate on how Zone 2 specifically activates it?
Certainly. PGC1 is switched on by upstream energy sensors. When you engage in sustained Zone 2 work, you get moderate muscle contraction, which increases intramuscular calcium levels. This calcium activates an enzyme called CAMK.
Right.
At the same time, the sustained effort causes a slight drop in the cellular energy charge, the ATP to AMP ratio, which activates another key enzyme, AMPK.
So you have this dual activation.
Exactly. Both KMK and AMPK act as potent activators for PGC1, yes. And it's this sustained low-grade activation, typical zone 2, that is arguably metabolically superior to the brief, acute signaling you get from very high-intensity work.
That dual mechanism, KMK responding to the work itself and AMPK responding to the energy stress, really explains why it's such a direct promoter of mitochondrial health. And this translates into improved metabolic flexibility, doesn't it?
Precisely. Metabolic flexibility is the body's ability to seamlessly switch between burning fat and carbohydrates. By stimulating mitochondrial biogenesis and enhancing fat oxidation, Zone 2 reduces the body's reliance on precious glucose reserves.
Which improves insulin sensitivity and blood sugar regulation.
It does. And a decline in this flexibility is a core feature of many chronic metabolic diseases, which makes Zone 2 prescription a direct, drug-free intervention for metabolic dysfunction.
Beyond the cell, the cardiovascular gains are foundational. For a clinical review, what are the most pertinent changes we see in heart function and blood flow?
The adaptations are both central and peripheral. Centrally, the left ventricle strengthens and enlarges, leading to a significant increase in stroke volume, the amount of blood pumped per beat.
Which is why elite athletes have such low resting heart rates.
It's pure efficiency. Peripherally, we see a dramatic enhancement in capillary density within the muscles. This improved network shortens the diffusion distance for oxygen and nutrients, which is vital for supporting high-volume training.
And finally, that cellular cleanup element autophagy and the link to telomere protection.
Yes, sustained moderate stress activates autophagy, which is the process of recycling damaged cellular components. This is crucial for cellular health. And while excessive high-intensity training can increase oxidative stress, which may shorten telomeres, Zone 2 appears to promote an environment that supports telomere integrity.
So for the general population, what's the prescription?
For the general population, a consistent volume of Zone 2, say 150 to 300 minutes per week, is arguably the single most effective prescription for delaying the onset of age-related metabolic and cardiovascular decline.
Now that we've established the deep physiological significance of aerobic capacity, let's examine how elite athletes structure their time to maximize those adaptations. We often hear about 80-20 or polarized training. What does the evidence actually suggest about intensity distribution?
This is a complex area, and it's often oversimplified by that 80-20 tag.
Okay.
We define training intensity using a three-zone model, anchored to ventilatory thresholds.
Okay, so zone 1 is easy.
Zone 1 is easy below the first threshold, VT1. Zone 2 is moderate to heavy, between VT1 and VT2, and Zone 3 is severe, anything above VT2.
And how did the distribution models fit into that framework?
Well, polarized POL training is characterized by a very high volume in Zone 1, typically 75–80%, and then a significant portion in Zone 3, maybe 10–25%. The key is an explicit effort to minimize time spent in that middle Zone 2.
So easy days are very easy, and hard days are very hard.
That's the mantra. In contrast, the threshold THR model focuses squarely on that middle zone. In rigorous studies, a THR model might have 30–35% of total volume in Zone 2, training near that lactate threshold.
That comfortably hard feeling.
Exactly. But repeated sessions there often lead to chronic fatigue without providing the maximal stimuli for high-end gains.
A meta-analysis comparing these two extremes showed a moderate effect size favoring the polarized approach. What's the critical context we need to consider with that finding?
The effect size does support the theoretical advantage of POL over THR in high-performing athletes. But the critical context is that this comparison forces a dichotomy that, well, it often doesn't exist in the real world.
It's not that black and white.
Not at all. The meta-analysis provides strong evidence that the threshold model as an exclusive strategy is suboptimal. But that brings us to the pyramidal PYR distribution.
Right, so if POL is roughly 820, what does PYR look like? And why is it maybe a more accurate description of what many elites actually do?
Pyramidal is still dominated by Zone 1, but it includes a moderate substantial volume in Zone 2 with the least in Zone 3. So, for example, 8–155.
So the difference is whether Zone 2 is intentionally avoided or simply limited.
Precisely. And the vast majority of successful endurance programs, including the sophisticated models from top Norwegian runners, are fundamentally pyramidal. They maintain high overall volume, but integrate targeted Zone 2 work.
So the famous 80-20 ratio isn't a magic prescription, but more of an inevitable consequence of very high training volume. What's the implication of that for the amateur athlete you might see?
It's a huge implication. For an athlete training 15 hours a week, 20% is 3 hours of severe stress, a massive dose. If an amateur trains just 5 hours a week, 20% is only 1 hour.
Not enough stimulus.
Potentially not. A professional has to do a tremendous volume of Zone 1 just to support the adaptation from their key sessions. For a lower mileage athlete, say under 70 or 80 kilometers a week, rigidly sticking to 80-20 might reduce their intensity volume too much.
And we should be measuring this by time spent in the zone, not by mileage.
Ideally, yes. Mileage is easy to track, but it's an unreliable proxy for physiological stress. The key adaptive signals are entirely dependent on the duration of exposure to a certain state.
Because 5 miles on the flat is a very different stimulus to 5 miles in the hills.
Completely different. Measuring time in zone via heart rate or power gives you the true physiological experience.
Let's focus on that medium rut. For the clinician, what are the telltale signs that a patient is stuck in this moderate intensity trap?
The patient will present with chronic fatigue, performance stagnation, and an increased susceptibility to illness or injury. Physiologically, they are in no man's land.
They're not going easy enough on their easy days.
And not going hard enough on their hard days. They accumulate fatigue from Zone 2, which inhibits recovery, but they never quite trigger the maximal signals for adaptation from Zone 1 or Zone 3. It's the physiological equivalent of perpetually spinning your wheels.
Here's where it gets really interesting for our audience. Many athletes, especially runners, integrate resistance training for injury prevention and power. This concurrent model is a staple in orthopedic rehab. But we face the issue of the interference effect. Unpack that molecular conflict for us.
The interference effect is often described as a clash between two master signaling pathways, AMPK and MTOR.
Right, we've already met AMPK.
Yes, activated by the energy stress of endurance training, promoting catabolic processes like mitochondrial biogenesis. Conversely, resistance training maximally activates the MTOR pathway, which drives anabolic processes like protein synthesis and muscle hypertrophy.
So when you do both close together, the activation of AMPK from the run is thought to inhibit the MTR signaling needed for strength gains.
Precisely. The signaling is competitive. Chronic, high-volume endurance work can dampen that anabolic MTR response. So the athlete might be lifting heavy, but the molecular message to build muscle is being blunted by the residual stress from their run.
What are the key practical factors that modulate how severe this interference is?
Beyond frequency and intensity, the two most critical factors are exercise order and the mode of endurance exercise. The sequencing matters profoundly, and the type of stimulus running versus cycling, for instance, can dictate the severity.
Okay, let's focus on the mode. Why does running typically cause more interference than cycling?
The primary hypothesis centers on the high degree of eccentric loading inherent in running.
The braking forces.
Exactly. Running, particularly downhill, causes greater microtrauma and muscle damage than cycling. This leads to prolonged inflammation and fatigue, which exacerbates the neuromuscular impairment that resistance training is trying to overcome. The body is essentially preoccupied with repair.
Let's delve into that specific load velocity study you've reviewed. It provides a granular look at these trade-offs, particularly with the sequence of resistance before endurance. Unpack the methodology for us.
This was an 11-week study with already trained individuals. The key setup for the concurrent training group was performing their resistance session heavy squats and so on, followed immediately by their run, with only a 20-minute rest.
And that short break was deliberate.
It was. It was chosen to minimize the acute fatigue effect on the resistance session itself, making it a very strong test of the subsequent interference.
What was the critical finding regarding explosive strength, measured by counter-movement jump height?
The CMJ, a robust measure of lower body power, proved to be the most vulnerable adaptation. During the initial 5-week phase, the resistance-only group saw a significant 5% gain in their CMJ height, the concurrent group.
Nothing.
Essentially zero improvement.
That is a fundamental constraint, and this was even when sequencing the lifting before the run, which is often recommended. Why would it still completely negate the gain in explosive strength?
It suggests that the chronic interference effect over those 5 weeks was potent enough to block the specific neural and muscular adaptations for explosive power. Even though they lifted heavy, the metabolic environment created by the subsequent running blunted the translation of that strength into functional power.
Which has huge clinical implications for orthopedic rehab. If you need to rebuild explosive strength post-injury while maintaining an aerobic base, how should you tailor the program?
Strategic sequencing becomes mandatory. The consensus suggests separating the training modes by a minimum of 6 hours, and ideally more like 10 to 12. This allows the signaling pathways to return to baseline.
And if that's impossible?
Then you must prioritize the most important adaptation. If explosive strength is the clinical goal, the resistance session must be first, and any subsequent endurance work must be very low intensity to minimize that AMPK activation.
The study also showed delayed aerobic gains in the concurrent group. What did that tell us?
Yes, the improvement in their first ventilatory threshold, VT1, was noticeably delayed compared to the endurance-only group. This implies that the cumulative fatigue from the heavy lifting acted as a systemic suppressor of aerobic adaptation.
So there's a significant physiological tax.
A significant tax on both strength and endurance outcomes when performed concurrently without adequate separation.
If we connect this to the bigger picture, the sheer volume of training necessitates incredibly sophisticated fueling. For an Ironman, nutrition transitions from a choice to a matter of physiological survival. What are the key demands underpinning this?
The demands are truly colossal. An Ironman can require an energy expenditure of 8,500 to 11,500 kilocalories. The body is fundamentally limited by its relatively small storage of glycogen, less than the 3,000 kcal, compared to its virtually limitless fat stores.
So why is carbohydrate still the primary limiting factor, even with all that fat available?
It's about kinetics and energy yield.
Yeah.
While fat oxidation peaks at around 60% of VSHO max, the rate of energy production from fat is too slow to sustain race pace.
Which is typically higher.
Much higher, usually above 70% VSHO max. Carbohydrate provides a higher energy yield per liter of oxygen. So fatigue is strongly correlated with the depletion of muscle glycogen, which usually happens around the 2 to 3 hour mark.
And this inherent limitation is why nutritional strategies have evolved into this complex carbohydrate periodization framework. Can you explain that shift away from just universally high-carb diets?
Of course, the traditional high-carb diet maximizes glycogen stores, but it potentially limits the body's ability to develop robust fat oxidation pathways. Periodization uses nutrition as a training tool, strategically aligning carb intake with the goal of the session.
Let's detail the train low strategy. How is this implemented, and what's the molecular adaptation it's targeting?
Train low means starting specific, usually longer and lower intensity, sessions with reduced glycogen stores. The nutritional stress mimics the low energy charge of intense exercise, which maximally activates that AMPK pathway we've been discussing,
To enhance fat oxidation capacity.
and to boost the expression of mitochondrial enzymes.
What are the practical protocols for this? I'm thinking specifically of the sleep low, train low method.
The sleep low, train low protocol is perhaps the most advanced. The athlete performs a glycogen-depleting session in the evening, say high-intensity intervals. Then, crucially, their evening meal is severely carb-restricted.
They go to bed with low glycogen.
Exactly. They then wake up and perform a low-intensity fasted endurance session the next morning. This maximizes the time the muscle spends in that low glycogen state, amplifying the signaling for mitochondrial adaptation.
And it works.
Studies have shown it can lead to time trial performance improvements of 3 to 7%.
Conversely, the train high strategy remains essential. When must an athlete prioritize full glycogen stores?
It's non-negotiable for all key high-quality sessions. Anything over 75 minutes, or efforts with substantial work above 70% VSHO max. The goal there is to ensure high power output and maintain the quality of the speed work.
And train high is also the necessary vehicle for training the gut.
Absolutely. The gut is highly adaptable. Training it means regularly exposing it to the high volumes of carbohydrates you intend to consume on race day. This practice upregulates the transport proteins in the small intestine, improving absorption capacity and reducing GI distress.
Focusing on daily guidelines, what is the sheer scale of carbohydrate intake for someone training over 4 hours a day?
The requirements are stratified. On a rest day, 3 to 5 grams per kilogram of body mass might be fine. But for high-volume training over 4 hours a day, that recommendation escalates dramatically to 8 to 12 grams per kilogram.
For a 75-kilo athlete, that's nearly a kilogram of carbs a day.
It is, which requires very careful planning.
Let's look at race fueling, starting with the pre-race CHO loading. What are the key elements of that 36 to 48-hour window?
It involves consuming that 8 to 12 kilograms of body mass alongside a significant exercise taper. The goal is to supersaturate glycogen stores. And it's important you advise patients that this will cause a 1 to 3% body mass gain from water retention.
And that's a normal, necessary consequence.
It is. Also, emphasizing low-fiber foods during this phase is vital to mitigate race day GI issues.
The critical phase is the in-race intake. We often hear the 90 grams per hour rule. Why is the composition of that 90 grams so vital?
Because the small intestine has a limit to how fast it can absorb a single type of carbohydrate. Glucose is absorbed via the SGLT1 transporter, which gets saturated at about 60 grams per hour.
So you can't just consume pure glucose gels.
You can't. By introducing a second, different sugar, typically fructose, which is absorbed via the separate GLUT5 transporter, you bypass that saturation limit.
So using a 2.1 ratio of glucose to fructose achieves what outcome?
It allows the athlete to maximize their intestinal absorption rate up to 90 grams per hour, and potentially even higher. This provides significantly more fuel to the working muscles.
And the advice is to get that in during the cycling leg of an Ironman.
Yes, because intake tends to fall drastically during the high-impact run due to increased GI distress.
Moving to hydration. Athletes lose a lot of body mass during these events. What are the current guidelines on fluid and sodium, especially with the risk of hyponatremia?
Well, while dehydration over 2% body mass is linked to performance decline, Ironman athletes routinely finish having lost 4 to 8%. The current best evidence strongly advocates for drinking to quench thirst.
Not drinking to a preset schedule.
No. Excessive forced intake, especially of water or low-sodium fluids, carries the serious risk of exercise-associated hyponatremia, a potentially fatal condition. The goal isn't strict weight maintenance. It's balancing fluid loss with sodium homeostasis.
A vital warning for the clinician. The use of NSAIDs. What is the explicit risk here?
Athletes must be firmly advised to avoid NSAIDs like ibuprofen, especially in the days leading up to and during competition.
Why is that?
NSAIDs compromise the tight junctions in the intestinal wall, significantly increasing intestinal permeability, a leaky gut. This allows toxins to cross the gut barrier, exacerbating GI complaints and potentially causing systemic inflammation.
Given that so many athletes suffer GI issues, are things like probiotics and glutamine proving useful?
The emerging data is promising. Supplementation with probiotics and glutamine may offer a protective effect. Glutamine is a key fuel for gut cells, and probiotics can help stabilize the microbiome. They're a supporting strategy, not a cure, but they can help.
So what happens when that delicate balance between training stress and recovery is fundamentally broken for months on end? This brings us to the serious and often misdiagnosed overtraining syndrome, or OTS.
OTS represents the far end of the maladaptation continuum, and it's imperative for clinicians to differentiate the stages as the prognosis and rest periods vary dramatically.
Let's define those 3 stages clearly.
The spectrum starts with functional overreaching, FO. This is a temporary performance drop, a few days to 2 weeks of rest, after which the athlete supercompensates. It's actually part of effective training.
I think it's more serious.
Next is non-functional overreaching, NFO. This involves a performance decrement lasting weeks to months with psychological symptoms, but full recovery is still achievable.
And then the clinically significant entity overtraining syndrome, OTS.
OTS is extreme NFO. It's defined by a performance decrement lasting greater than 2 months, coupled with severe multi-system symptoms, neurologic, endocrine, immunologic disruption. It's rare, and its development was often triggered by a significant non-training stressor on top of the training load.
Given the systemic nature, fatigue, depression, immune suppression, what is the most comprehensive theory uniting this complex pathophysiology?
The prevailing and most robust explanation is the cytokine hypothesis. It posits that OTS is fundamentally a state of chronic systemic inflammatory failure.
So how does the local microtrauma from training escalate into this systemic state?
Excessive mechanical stress triggers the local release of pro-inflammatory cytokines, like IL-6, IL-1, and TNF-A. Initially, this is adaptive, but when recovery is perpetually insufficient, these cytokines spill over into the circulation, creating a pathological systemic inflammatory profile.
And these systemic cytokines then directly impact multiple body systems, including the brain.
Exactly. They cross the blood-brain barrier and act on the hypothalamus, inducing what's termed sickness behavior. This explains the key psychological symptoms of OTS: anorexia, depressed mood, irritability, severe sleep disturbance. The inflammation essentially hijacks the central nervous system.
And what about the classic hormonal imbalances and muscular fatigue?
The cytokines activate the HPA axis, leading to chronically elevated cortisol. At the same time, they suppress the gonadal system, leading to lower testosterone. Metabolically, they may also interfere with muscle glucose transport, reducing GLUT4 transporters, which contributes to that feeling of perpetually heavy legs.
And we also see the immune vulnerability, the frequent upper respiratory tract infections.
This is linked to the shifting cytokine milieu. The chronic inflammatory state favors a shift towards a Th2 lymphocyte profile, which downregulates the Th1-sponsored cell-mediated immunity crucial for fighting common viruses.
This brings us to the immense challenge of clinical diagnosis. Given the overlap with conditions like chronic fatigue syndrome or thyroid dysfunction, how should we, as clinicians, approach this?
OTS is fundamentally a clinical diagnosis of exclusion, made retrospectively. The history and symptom profile are paramount. Key clues are unexplained underperformance that persists despite months of recovery and profound mood changes.
We often look for objective data. Why is there a persistent lack of specific, validated lab markers for OTS?
Because most biochemical markers are highly responsive to normal training strain. Creatine kinase and urea levels rise after any intense session, the classic testosterone. Cortisol ratio is fraught with limitations due to circadian rhythms. It's just not reliable.
What about heart rate variability, or HRV? That intuitively seems like it should be a solid measure.
The research has been inconsistent. While it can show a shift towards sympathetic dominance, the utility isn't high enough to be a standalone diagnostic tool. There's too much individual variability and sensitivity to non-training factors.
So if lab markers are unreliable, what are the most sensitive indicators we should focus on?
We must rely heavily on validated psychological markers. The Profile of Mood States, POMS questionnaire, is the gold standard. In OTS, POMS consistently reveals the inverse iceberg profile. Low scores in vigor and high scores in fatigue, depression, and anger.
So the psychological state is often the earliest and most robust sign.
It is. That and the athlete's self-reported rating of perceived exertion, RPE, for a standard workload. If the RPE for a pace that used to be easy is now significantly and sustainably higher, that's a huge red flag.
When you have confirmed NFO or OTS, what are the key principles of management?
The primary treatment is rest. But given the strong psychological component, anxiety, depression, loss of identity, integrating a sports psychologist is crucial. Complete cessation of activity can sometimes make things worse.
So a more nuanced approach is needed.
Yes. Relative rest, starting with just a few minutes of low-volume movement and slowly building up, can be a more psychologically tolerable approach. The focus must shift entirely from performance back to restoration of systemic health.
So what does this all mean? The complexity of optimizing training, from the molecular drivers of Zone 2 to the sequencing needed to mitigate interference, it all reinforces the need for precision and rigorous monitoring, particularly for that serious amateur athlete.
I believe we can synthesize 3 vital concepts for the medical professional dealing with these patients.
Okay.
First, training structure must be intentional. Clinicians need to recognize that the effectiveness of polarized methods is contingent upon the athlete achieving a high-volume threshold. For those with lower weekly volumes, a rigid 80-20 might actually inhibit the necessary speed stimulus.
Right, it's not a one-size-fits-all rule.
Second, concurrent training, particularly in runners, presents a significant risk to acquiring explosive strength, a critical component of injury resilience. This demands highly strategic programming, separating sessions by at least 6 hours.
So monitoring explosive capacity is more important than just their squat 1-rep max.
Far more important. And third, OTS is a devastating systemic inflammatory failure. Clinical vigilance relies heavily on a detailed history, ruling out all organic disease and consistent monitoring of the athlete's psychological state with tools like the POMS. Be cautious about relying on expensive or unvalidated lab tests.
If you found this discussion valuable in deepening your own understanding or helping your patients, please do rate and share the deep dive with a colleague.
Thank you.
Finally, a provocative thought to leave you with. Consider how much of modern chronic fatigue and stress in the general population might reflect a mild, undiagnosed form of non-functional overreaching, stemming not from high athletic load, but simply inadequate recovery from non-training life stressors. Could prescribing targeted Zone 2 work and enforced rest be a novel public health intervention?